Welcome to the Docs Who Lift podcast, where we distill and simplify the complexities of a healthy lifestyle, exercise, medicine, and weight loss. We're excited to bring you a podcast that's a prescription for clinical practice, scientific recommendations, and just real life. This is the Docs Who Lift podcast.
Hoy, hoy, hoy. Welcome back to the Docs Who Lift podcast. I'm your host, Dr. Spencer Nadolsky, co-host Dr. Karl here, and we're today going to be talking about the recent Lancet Commission for the definitions of obesity, clinical obesity. Proposed definitions.
Yeah.
It's kind of been a big deal this week. People are talking about it. Also, top-line results. We get a lot of these top-line results, and then we go over the study once it's published, and once again, there's some top-line results from
That's many months later, years later. Yeah. And then we have to go back and.
So then
I hate that they do this actually. Kind of.
Yeah, and then it sounds like we just keep kind of repeating ourselves a little bit. But top-line results of something called the Step Up trial, where they actually tripled the dose of Wegovy, the 2.4 milligrams. They tripled it to 7.2, and we were just looking before this because we're like, was there a titration up to there? So no, they did the 0.25, 0.5, 1 milligram, then 1.7, then 2.4, and we figured there'd be some doses in between, but it looks like they just tripled it and said, screw it, let's just go to the 7.2. And they looked over the course of 72 weeks as opposed to the usual 68 that they do, kind of mimicking tirzepatide SURMOUNT trials. But the STEP trials were only 68 weeks, or some of them were longer, of course, when they extended it out. But they put it at 72 weeks and kind of some interesting results there. So what do we want to talk about that?
Well, I mean, you're talking about it right now. I think, so to give people a little bit of background, they're looking at semaglutide for obesity. So originally approved for type 2 diabetes as Ozempic with a dose of 0.5 or 1 milligram, and then later on 2 milligrams per week with very good weight loss and blood sugar control and type 2 diabetes, and then approved as Wegovy at what you're talking about, the 2.4 milligrams weekly. And of course, it's a long titration to get up to that because of the GLP tolerance issues that people face, which is why we're surprised that they were able to just apparently jump right from 2.4 by tripling it to 7.2. Now, obviously, there were some sort of research data before that led them to think they could do that. I mean, there's no way, talk about big pharma. There's no way they'd put all that money into doing a huge trial because of how expensive it is if they didn't think that was reasonable. And of course, the top line results, they don't give us the exact statistics, but it does say the tolerability was similar, right? That's what it said.
That's what it says.
So we'll see the actual.
Yeah, it's a press release, and that's the issue. So we don't have the nitty gritty of it. There's top line results. So here's the gist: the top line results were that 7.2 dose got 20.7% total body weight loss over the course of 72 weeks, and that is compared to though the 2.4 milligram dose, which somehow got to around, what is it, 17?
Around 17, which is very similar to the historical Wegovy trials. Remember,
it's a little bit more. It's a little
slightly
bit more.
Different populations, but how they're done, how well people adhere to the plan. Do people drop out of it? That sort of thing. So there's a lot that goes into it, but that's in the realm of obesity without type 2 diabetes, how much weight loss they were getting. And I don't know, did it even say the placebo group, or was there not a placebo group?
No, there is a placebo. There is a placebo. Let me see if I can open it up real quick while we're talking about this.
Because generally, the 2.4 milligrams in obesity, we've kind of talked about the different trials, but 15% more than placebo, generally speaking. On average around 16%. So that it's in the realm. But did it say what the placebo was on that?
The one thing I do know is that the people that got to the 25% total body weight loss, how they look at the categorical weight loss,
which I think is really important. A lot more people were able to achieve that 25% weight loss.
Yeah, it's like
right.
Double.
It was wasn't it like a third?
Well, they doubled from what it usually was. Let's see. Okay, here I go. I got it. I was looking at the one of these other
People listening to this are like, God, I could have just read the damn thing myself.
These idiots. Yeah, no, 33% got the 25.
So, yeah, I mean, and the thing is, but that's a much higher dose. We've talked about the recent trials that were finally, again, just not even published necessarily, but the cagrilintide with the semaglutide that, I always expected would be the one that would be more competitive with tirzepatide, the Zepbound Mounjaro version, which, it is, even though, of course, the media headlines and the the stock market all thought, oh no, it didn't beat it. But I think people need to realize when we start getting into this realm of weight reduction, remember, that's what matters is what's on the inside that counts. It's, well, how much weight reduction is necessary to ameliorate the obesity-related diseases. And this will be a good segue into what we're going to talk about with the Lancet Commission. But 10% weight loss is now kind of becoming the standard, because that's where you really prevent diabetes. You really treat high blood pressure, triglycerides, lipid abnormalities, knee arthritis, sleep apnea, and all that stuff. And then when you start getting over 15%, you're really, really, really achieving all the health benefits that we care about. And so the more people we can get past that goal, the better. And so these 15, 20, 25% weight reductions that these medications are getting, that's a big deal for people.
Yeah, but if you can't get abs, if you don't get over that, or not everybody had abs in utero like that. Yeah, so Jesus. It does look like it does say the similar tolerated profile compared to 2.4. I don't know how that's possible, but I don't know. Maybe once you get to past the point, it's like, whatever, there's just a little bit more satiety.
But it also wasn't like on average a ton more weight loss on average. But I think your point is important, that it was a lot more people achieved those really, really important categorical weight reductions. So that's great. And so we'll look forward to seeing the actual publication next year.
Yeah. And well, also, I was just going back to the cagrilintide, the CagriSema. I mean, imagine taking this dose then and putting it with the cagrilintide. So like you start,
someone's got to know something.
Incrementally improving it. So there you go.
Yeah. We need to.
Now, the other thing we keep saying is that, like, look, the elephant in the room is the stuff's not affordable right now. The stuff is not in great supply. It's still on, as we speak right now, January 17th, 2025. It's still technically in shortage with the on the FDA shortage list. So we'll see if it comes off, I think, here and within the next few weeks. All doses are apparently available with Ozempic and Wegovy, but they need to crank up production. And I think they need to put these in the vials as well and create a direct-to-consumer ability, just like Lilly has. So we'll see what they do. Lilly, Novo, I know you're listening. Some of you guys listen, gals too.
God knows they don't pay us, like everyone thinks. But
no, they do not pay us. Okay, let's
get
into
after I give up.
Let's get into the Lancet Commission definitions of obesity, clinical obesity. What is it? What did they come out with?
Okay, well, so about a year and a half, or about a year ago, there was the first publication essentially saying, "Hey, this is what we're doing." And essentially, this was commissioned by Lancet, the very famous, internationally famous medical journal out of Europe, and specifically was going to be published in the Lancet Diabetes and Endocrinology specific journal. And so their specific aim was to establish objective criteria for the disease diagnosis and define clinical obesity, and that's what we're going to get into, as a condition of illness that is similar to other chronic diseases in different medical specialties, with the focus on, well, how does the disease directly result from excess adipose tissue on the function of organs and tissues and all that stuff. And so, my initial impression was, okay, wow, so this is like an international effort. They have over 50 experts, many of whom, we know, some of who have been our mentors and colleagues. In fact, remember Dr. Fatima Cody Sanford, who actually we're going to probably publish her podcast after this. She talked about this a little bit. So she was involved. Some of the mentors I've had, one specifically, Dr. Garvey, who was the head of our
He wants to come on the podcast. He keeps asking
we're going to get him on the podcast.
Keeps asking.
Yeah, we'll get him on the podcast. We just had a meeting last night with a little bit about this commission because we're in the middle of updating our American Association of Clinical Endocrinology obesity guide. It's not really a guideline anymore, but the algorithm, the clinical algorithm. And back in 2014, 2016, I was involved in some of this a little bit as a kind of a junior person, because it was a real priority to start getting away from defining obesity, which was established as a disease, at least in the United States and then around the world, but getting away from BMI. And everyone has been in agreement, basically since you and I were in medical school, that body mass index, BMI, is very good for studying the populations because it's very much correlated to the amount of adipose tissue people have on average. But on an individual basis, it's not very good just to make one diagnosis. For example, when we were at our prime, had very, very low body fats, but we were into those overweight, sometimes knocking on the door of obesity classifications, class 1, and obviously did not have obesity. So this has been a problem for a long time. And so what we did was we said, well, one, the BMI can help you screen for people, but you really have to confirm that on your exam, that yes, it is consistent with excess adipose tissue. Use waist circumference measurements to say, do they have increased cardiometabolic risk type obesity? And possibly consider, body composition analysis, et cetera, to help you make that diagnosis. But more importantly, we talk about staging the severity of the disease, where now we've kind of updated it to stage 1, where they don't really have any other related problems from the obesity. Now, we used to call them complications. This is where this commission, some of these definitions I think are going to cause some confusion. But basically we would say, and then stage 2 is like mild to moderate obesity complications. And then stage 3 is severe, like type 2 diabetes, heart disease, kidney disease, severe sleep apnea, et cetera. And that helps us decide, well, how much more aggressively do we need to be? How urgent does therapy need to be? Do we need to use medicine? What medicine, surgery, et cetera? And so the background of this, so they wanted to get a more of an international consensus. So this is not a guideline necessarily, but they had these 58 experts representing multiple medical specialties and countries. They had people who have lived with obesity to give kind of the patient perspective, and they participated in what sounded like a very, very potentially frustrating series of debates to try to come to some sort of consensus on these different definitions. And ultimately, I think it's actually very similar to what we have proposed, and then the European Association for the Study of Obesity kind of followed on with that staging that we call it kind of the adiposity-based chronic disease state. But these definitions that they finally came to a consensus on are slightly different, and I think it'll be interesting to see how this plays out and how it's debated. I can kind of go right into it if you want, but do you have any?
No, go into
the
it.
background of it.
No. I mean, this is debated forever. Everybody wants to somehow get rid of BMI. We'll get into that in a second. It's not possible at the moment, and that was a big deal because when they go to some of these countries that don't have some of the technology. I mean, I was hearing some of the background from some of the authors. It's just like some of these places, like we don't have access to XYZ. So
And a lot of, primary care, we're going to have some body composition technique opportunities, et cetera.
I'm literally starting a study and doing DEXA, but that's not the norm.
How it is in primary care.
That's not the norm.
So,
that's not the norm.
So after round and round and round of all these different discussions they had, this is ultimately what they came up with. So the commission defines obesity as characterized by excess adiposity, so fat tissue, with or without abnormal distribution. So that gets into the abdominal obesity, which is increased cardiometabolic risk stuff. And it says with or without that, and with causes that are multifactorial and still incompletely understood. So that's like a one-liner for how complex general obesity is. Why people are gaining adipose tissue, how it's adversely affecting people, why it's hard to lose weight, et cetera. All those things we talk about, why conceptually, it is a disease state. However, this got more into the weeds with them. So they came up with this concept of clinical obesity. So they define clinical obesity as a chronic systemic illness characterized by alterations in the function of tissues, organs, the entire individual, or a combination thereof, due specifically to the excess adiposity, which can lead to severe end organ damage, causing life-altering and potentially life-threatening complications like heart attacks, heart failure, stroke, kidney disease, etc. Now, I don't know that I even want to get into some of these other semantics that, because I debated this all last night, is that then they started somewhat separating these definitions of obesity-related diseases and obesity complications, whereas the complications are almost like hard endpoints, like kidney failure, very, very severe knee arthritis where it's debilitating, stuff like that, where it's like structural, like end organ like damage. It gets very confusing, but when you look at the final publication, I swear it makes it look like they kind of mix them all together. So, for example, obesity-related disease like insulin resistance, metabolic syndrome, type 2 diabetes, for example, as opposed to complications per se. So I think that part's going to cause a lot of confusion, but it doesn't necessarily matter, because ultimately any abnormal function of a person due to excess adipose tissue is going to be put into the bucket of clinical obesity. So compared to what we used to, or what we still call stage 2 and 3 obesity or adiposity-based chronic disease, that's basically the same as clinical obesity. They define preclinical obesity as a state of excess adiposity with preserved function of other tissues and organs and a varying but generally increased risk of developing clinical obesity, and obviously those several other non-communicable diseases like type 2 diabetes, cardiovascular disease, certain types of cancer, and mental disorders. And we know that sort of that stage 1, so that's the same thing as what we call stage 1 obesity. From a metabolic perspective, we've talked about it's metabolically healthy obesity, but that's actually pretty rare. Usually they're younger, lots of good physical activity, good nutritious diet, even though they may have excess adipose tissue. But it's not, it doesn't have a benign course most of the time. And that's the problem. So they're kind of trying to toe this line a little bit of disease, what requires more intensive therapy and not. So, and they do mention that the risk of mortality or death and obesity-associated diseases can rise as a continuum across increasing levels of fat mass. So, for example, the more adipose tissue one person holds on to, accumulates, especially if it's abdominally, that the more there is, the more risk there is in the future of developing other related diseases. And that can, go across the board for almost everything. And to differentiate between preclinical and clinical obesity is essentially health versus illness is what they're trying to do for clinical and policy related purposes. And so I don't know if that just, was a bunch of, if that made it clear as mud or not, but I took a lot of that was basically quoting in shorter sentences, believe it or not, what their paper says without digging too deep into the weeds.
Yeah, what most people's concerns are about, like this, delineation between preclinical and clinical
Right.
obesity, and then worried that if they have preclinical, or the insurance company is going to use this as a reason to stop their GLP-1 medicine and all this different stuff.
Yeah.
Honestly, when you look closely at people, most people have some bit of
that's the thing. It is very difficult to have a completely preclinical obesity, a state of preclinical obesity, or the way we stage them in our guidance, a stage 1 obesity. But it's being, again, younger people who have been exercising a lot, who have a nutritious quality to their diet. in fact, they have a little picture in the publication where they have two buckets, people who have an elevated BMI, right? And they had one really jacked boxer, I think is what they had. That person has a BMI that's elevated, but he has no body fat. He's very healthy. He does not even have obesity.
It's Mike Tyson.
Is that what it looked like, Mike Tyson? And that's kind of, maybe back in our day, that's how we were. I don't think my BMI is into the over, or well, it's not over 27 anyways, not the point. But then, in the other box, then it split it in two, and it had someone with obesity, significantly excess adipose tissue. But, it has the person running. I'm not a big fan of the pictures actually in this case, but it had a person running and it said they're completely healthy. They have no mobility problems. They feel well. They're mentally healthy. Life is great. Everything's good. There's still a future risk of developing the clinical problems, though, that come along with obesity, whether it's obesity-related disease or complications, how they want to, sparse those hairs. Again, I personally don't think it matters that much. And then it had a picture of a person with obesity kind of struggling, I think, on the side of the bed. And, that person has limitations. It could be physical limitations, mental health disease, metabolic complications, and all that kind of stuff. And so that's kind of how they're divvying that up. And then kind of going back to this whole BMI, well, how the heck do we diagnose it thing? And I think what they wrote in there is almost darn near identical to what we published back in 2016. And that is that they recommend that a BMI should be used only as a surrogate measure of health risk at a population level or for epidemiologic studies, but for individuals only for screening purposes rather than an individual measure of health, which is true because everyone's different and everyone's, needs more personalized evaluation. So they say the excess adiposity should be confirmed by either direct measurement of body fat, which is, all these different body composition analyses. But they say, obviously, if available, or at least one other anthropometric criterion. And that's like the waist circumference, waist hip ratio, waist to height ratio, in addition to BMI and a physical exam saying, yes, this person has excess adiposity. And then, they go on to say validated methods and cutoff points, which is why we use these things, which is why BMI is still around, because it's been so entrenched into the research. And but again, it's all population-based stuff. Different and different populations with different genetic backgrounds have different numbers that correlate to the increased risk of what we will now refer to in this case of clinical obesity.
Yeah. I mean, look, it's going to be confusing for people. People aren't going to be able to get past the BMI for a long time. Ideally, you would walk through a door and it would scan your whole body and then have that be that. We're not there. We're not even close to there. Although, Grant Tinsley, who's been on the podcast, Dr. Tinsley, has done some validation studies of iPhone scanning that kind of look at body shape. That's a kind of another option, and actually does a really good job with anthropometric measures such as waist circumference. One issue with telling everybody to do a waist circumference is that people don't know how to do it, and that's not an excuse to not try to do it. But imagine having different medical assistants or whoever's trying to do it all the time, and there's some variation there as opposed to stepping on a scale and getting your height. It's just so easy. That's why it's done. I don't know. I mean,
but I think to be honest, a physical exam in our world, when we see someone with a BMI that's in the realm of, overweight, even just for Caucasian populations, we'll just use, for example, since we're Caucasian, I guess.
I'm absolutely Caucasian.
Yeah, you're very white.
I'm very
BMI 25 and essentially 29.9 is that classification of overweight in Asians, Southeast Asians with that background. It's a lower cutoff because they just have different adverse effects of their adipose tissue where it gets stored more in the abdomen, higher risk of type 2 diabetes. So that number from 25 goes actually 27 and a half or 27 for the overweight category, that where we start saying, well, we'll approve medication with complications, etc. Anyways, it goes down to 23 for them, and then 27 and a half for the category of obesity. But for us, it's like if someone comes in with somewhere in there for us as a patient, we can often just look at them and tell what's going on. And then we can, if we need to, we measure an abdominal circumference, a waist circumference, et cetera. But we're still going to do the other clinical screening that is required for these patients anyhow. And that's kind of where back in 2016, where our guideline went and said, look, regardless, if there's a question, we're going to check your metabolic health. Do you have dyslipidemia? Do you have insulin resistance? Do you have hyperglycemia? Do you have type 2 diabetes? We talk about a review systems. We learn, do they have sleep stuff? Do we send them for a sleep study? Do they have sleep apnea? Do they have knee arthritis? How's their internalized weight bias? Are they having mental health disorders? So these are all things that we're going to be
pretty much
doing
captures
anyways.
Everybody. I rarely see someone who's even relatively muscular coming in without a lot of these issues too. So it's I don't know. Even when I was a pretty big muscular guy, I definitely had obstructive sleep apnea. There's no doubt about it. My neck was huge.
Yeah, those are
18. It was like 18 inches. I couldn't breathe. Still can't breathe.
Yeah, but so that's the thing. If you're struggling with weight, if you have excess adiposity, we should be doing further evaluation to see, well, what harm is it doing? It's literally what's on the inside that counts. So the simple matter of it is, if you have obesity-related disease or obesity-related complications, however they want to split those up, then that's what they are calling clinical obesity. If you have excess adipose tissue, but this is kind of that whole healthy at every size. Well, there's a little something to it. If you are very, very healthy, but you have excess adipose tissue, you have the risk of progressing to clinical obesity. And that includes the risk of adiposity-related cancers, malignancies in the future, by the way. And we should still treat them. And that's going to be a priority when we're doing our algorithm. God forbid I'd spill any beans on that and get fired again.
Yeah, don't get fired.
But it's very important that when we, and this has already been published and even in my stigma paper from a couple of years ago, when you have very healthy, but you do have a state of obesity, and we call that stage 1, or this is preclinical obesity, it is not just a benign state. There is a risk of it getting worse, and it should be treated. Obviously, with nutrition, exercise, all the lifestyle things, some people are going to need some medical therapy to try to lose. We talked about the categorical weight loss, 5, 7, 10% weight to help really, really reduce the risk of those future problems too. But when you start, progressing into clinical obesity or stage 2 or 3 obesity, then we got to be more aggressive.
Yep, I agree. Well, that's it, folks. I don't know what else I got. We don't have much.
I don't know. I feel like that's going to really bore the hell out of a lot of people.
Yeah, whatever.
Once I started saying it, I'm like, God, this is boring. I don't think people are going to be that entertained by this.
They get the gist. They get the gist.
Basically, it's very literally what's on the inside that counts.
Yep.
Excess adiposity is bad. It's consistent with obesity. Whether it's really, truly, truly, truly healthy and you have preclinical obesity, that's fine. We still want to help you be healthy and probably lose some weight. If you have clinical obesity, you have a higher risk, and it's perpetual, and we got to help you.
And insurance companies need to keep paying, and the pharmaceutical companies need to bring down the amount for those who can't get insurance to pay. And
we need our dysfunctional healthcare system to improve, so all this stuff can actually work better for patients.
And GLP-1 or GTFO. Here's our outro.
Oh my God, that's not true.
This podcast is for entertainment and education and information purposes only. Remember, the physicians on this podcast are not your physician. It should not be considered professional or personalized medical advice. It should not be used to replace speaking with your physician or medical professional to discuss your specific health concerns. The topics discussed should not be used solely to diagnose or treat any condition. As a result, we are not responsible for any unwanted medical outcomes. The views and opinions discussed are of those of the host only and do not represent those of any other entities.